Hello, everyone, and welcome to Got a Problem with Your Knee? Ask Dr. P. My name is Luciano Vigilati, and I am a VFit specialist here at Victory in Motion, the home of knee repair, not knee replacement. We are so excited to welcome you to our weekly show. We have a ton of questions that were submitted to our school group, Got a Problem with Your Knee? Ask Dr. P, our Facebook group, Knee Repair, Not Knee Replacement, and our social media accounts at Victory in Motion 1. First thing is first, who is Dr. P? Dr. P is a board certified orthopedic physician, a sports medicine specialist, and a regenerative specialist. He is the founder and CEO of Victory in Motion and the creator of the trademarked knee repair, not knee replacement program. Victory in Motion's mission is to make the world knee replacement free by 2043. Yes, you heard that right. Knee replacement free by 2043. Dr. P has over 25 years in orthopedics and regenerative medicine, so he brings a wealth of knowledge every week to the show to be able to answer your burning questions. So without further ado, let's welcome Dr. P.
Hey Lucci, how you doing? Hi everybody. Thank you for coming today.
What's up? How are you? How are you?
I'm doing great.
Good, good. So we're going to start these questions off kind of talking about the knee repair, not knee replacement program that you initially started and are CEO of. And it's really the beginning, the beginning stages of the program. And it's what is a CDE? What is a comprehensive diagnostic evaluation?
So, what is a comprehensive diagnostic evaluation? A comprehensive diagnostic evaluation is a day, and it's almost kind of like a clarity day where we um, have somebody come in, a patient come in, and they are going to go through a full day of meeting with us and usually about a half day of a meeting with us. And they're going to get an evaluation by one of their regenerative medicine providers first, whether it's me or our PA, Jordan, or our orthopedic PA, Allison. And we're going to spend a good hour with that patient. And we're going to go over we're going to try to get as many old records as we can. We're going to go over all their old records. We're going to go over their extensive history, all their medications, their surgical history. We're going to take the time to do that. And most visits in the United States, doctors only spend an average of 7 minutes with their patients. So imagine 7 minutes versus a full hour. We're also going to do a full physical exam. I can't tell you the amount of times that I see patients and I do a physical exam on them and they're like, wow, that was amazing. And I'm like, well, what are you talking about? And they're like, well, that's the first time anybody laid their hands on me or actually touched me. And so it's sad but true. That does happen where doctors will come in and they won't even do a physical exam. I'm not sure how you can tell someone give them advice on their knee if you haven't done a physical exam. That's just basic medicine. So we're going to do all that. We're also going to do a live ultrasound. So a lot of doctors don't do that, but it's kind of like our way of having, not x-ray vision, but ultrasound vision, look inside of the knee and watch the knee move dynamically. Like an x-ray is a static image. So is an MRI. They're just images that are without movement. But the ultrasound, we can look at movement and we can see how the structures move against each other. We can see if there's something loose floating around. We can see if there's fluid in the knee. We can see if there's swelling in the knee, all kinds of different things, inflammation. And so we're doing ultrasound, and then we'll also get a set of digital x-rays. A lot of times we see x-rays come where they're not weight-bearing x-rays. And so making sure we get the right x-rays, my doctor said I don't have any arthritis. And then we do x-rays that show the kneecap, which a lot of places don't get. And you see arthritis under the kneecap, and that's where the problem's coming from. So we make sure we get the right set of x-rays. And then we will do an MRI as well. And you might say, well, why do I need an MRI? I already know I have arthritis. Well, arthritis is where the cartilage on the end of the bone wears down, kind of like the tread on a tire. MRIs are going to show that. They're going to also show if there's any tears in the meniscus cartilage, which is the shock absorber cartilage in between the bones. They're going to show if there's any ligament problems, any muscle problems, any tendon problems. But the main reason we get it, and we use it for all those other reasons, but the main reason we order an MRI always, especially if there's been a diagnosis of arthritis or suspected arthritis, is to look at the bone underneath the cartilage. Because what happens is as the cartilage wears down, more and more force gets transmitted to the bone underneath, and the bone can break down faster and the body can heal itself. You can get these little stress or microfractures. and you won't see those on an x-ray. So we'll do an MRI as well. So we do all the diagnostic studies. Then we will also send you over to one of our VFit specialists like you, Victory Fitness, Total Body Fitness, Strength and Conditioning. So you guys are going to examine the entire patient, not just their knee. If they're coming in with a knee pain, you know, and I know that the ankle can affect the knee, the hip can affect the knee, the back can affect the knee, different areas can affect that knee. So you guys are going to evaluate their entire body. You're going to evaluate them from a mechanical standpoint, a dynamic standpoint while they're moving. You're going to look for deficits in strength. You're going to look for inequalities, all kinds of different things on a full evaluation. Again, as opposed to a 15 or 20-minute standard physical therapy appointment, this is a full hour. Not only that, you guys are going to do a complementary laser treatment on them because laser can decrease inflammation, increase blood flow, which helps healing, decrease pain, and also stimulates the mitochondria, the little powerhouse of your cells, so your cells work better. So that all happens. And then you're going to come back and see either myself or Jordan or Allison or a combination of us after the team meets and goes over that person's case, and everybody shares their findings. Then we're going to sit back down with that patient. We're going to go over all that, but we're also going to ask them many more extensive questions about, pretty much trying to figure out what their goals are and what they want to get back to. Because we use a lot of regenerative medicine techniques like bone marrow aspirate cells, which has stem cells and other cells that help the stem cells, PRP, platelet-rich plasma, which has platelets, which are kind of like growth factors, or fertilizer, which helps with healing. We use laser, which I just talked about. We use total body fitness. We use genetic-based anti-inflammatory nutrition. We use red light laser to get rid of fat and inflammation and weight. But we don't always use those the same way depending on what the patient's goals are. So we figure out what the goals are, and someone who has goals of being out of pain, sleeping through the night, walking their dog, we can handle that. Somebody who has goals of playing pickleball, that's a different set of goals than walking the dog. There are other people who want to ski. There's other people who want to hike. There's other people who want to run marathons. All those are different goals and require different programs using the same principles and tools that we have in our toolbox. So that's what that day ends up doing. We evaluate, we get the proper diagnostics, we get a total body evaluation, we go over all that, we figure out what the patient's goals are, and then we give them three options. I mean, you can kind of classify it this: good, better, and best. All of them are going to help the patient, but we give them three options and they get to choose which option they want to go with. But it's a personalized plan that will help you with your specific findings, your specific diagnostics, your specific total body evaluation, and your specific goals, get you to those goals. So bottom line, we're going to take our time with you. We're going to evaluate you. We're going to listen to you. We're going to physically examine you. We're going to do an ultrasound, diagnostic x-rays, MRI, a total body fitness evaluation. We're going to sit and figure out what your goals are, and we're going to give you a plan, all in as little as one day. Occasionally, it might take 2 days to get that done, but one day. And just if you look in the United States, the average time to get an MRI done, and a lot of people out there know this, I mean, it may take 6 to 15 weeks to get an MRI from when it's ordered, done, and get you your results. We do all this stuff in one day. So a lot of people have been through the insurance rigmarole where they have to do therapy first, or they have to go get an x-ray first, or they have to take anti-inflammatory medications. And it takes weeks and weeks and weeks and months to figure out what's wrong with them. And then even then, when we see these people months or years after they've been through this process, they still don't know exactly what's wrong with them. Imagine a day where we could figure all this out in one day, save you all those car trips, save you the back and forth, all the hassles, and we get that all figured out in one day. And a lot of people really, really, really appreciate it because their time is so valuable, and time is money.
100%. No, that's awesome. It's very in depth and it's very unheard of in the medical field. Seeing the patient for themselves and really understanding what's going on and getting down to the root cause of the problem is important, very important. Um, the next one we have, excuse me, next one we have is more away from our programs, since we try not to do surgery unless it's absolutely needed. But why does my quad shrink after knee surgery?
Good question. The quad will shrink or atrophy after knee surgery or after a knee injury. As you know, it might be an ACL tear or a sprain of the MCL, the inner ligament, or a meniscus tear, or a contusion. You got hit playing sports or fell down. So the knee will swell up. When the knee swells up or is in pain, there's a feedback loop that goes to the brain, and the brain shuts down the quad. We don't know exactly why that occurs, but we kind of one of the theories is that your brain, when you're injured, your brain doesn't want that to move because if you move it, it might make the injury worse, or at least that's the initial reaction, that your brain has. So your brain shuts down your quad and your quad starts to atrophy. And especially having fluid in the knee and swelling, that seems to also have another reason for shutting down that quad muscle. So it leads to the muscle getting smaller, atrophying. But that's where you guys come in, and we can overcome that by doing the right therapy, the right exercises, the right evaluations, and we can overcome that so that that quad doesn't atrophy. Because I think it's a evolutionary thing that developed, but it's not something that benefits us a lot nowadays, and we can overcome that. You guys can overcome that doing the total body fitness and getting the swelling out and having them work on exercises to keep that muscle strong so it doesn't atrophy.
100%. That you lose that quad quicker than you would anticipate, and it does take work to get it back. But working in VFit a lot, it does happen. It does come back. You just got to keep working at it. Um, the next one is, what is runner's knee?
What's runner's knee? Um, Runner's knee is usually pain in the front of the knee, anterior, and it's usually an overuse injury. People train too hard, too fast. The body starts to break down faster than it can heal itself. The most common reasons, and this is also called jumper's knee, by the way, and you see it in basketball players, and you being a basketball player, you know that. The tendon, the kneecap tendon, the patellar tendon that goes from the kneecap. Actually, I have a model right here. So the patellar tendon goes from the kneecap, the patella, down to the tibia, which is the shin bone. So from here to here. And when you run and jump, it gets stretched and it can be overused, and it can break down faster, and you can heal yourself if you either go do too much too fast or don't allow your body to recover. So you get tendonitis, inflammation, or eventually, if it continues, it can actually start to break down. We call that tendinosis. So that can give pain in the front of the knee. Same thing, the quad tendon that goes from the quad muscles we were just talking about and attaches to the patella, that can also get inflamed, especially the most common spots that it gets inflamed are right where it attaches to the bone because those are the weakest spots. You can also have wear and tear under the kneecap. We call that chondromalacia of the patella. So you can get pain from the kneecap itself. There's also in this space where my finger is going through here, it's not an empty space in the human body. There's actually a fat pad, a padding of fat that fits in there that can get inflamed. There's even little bursal sacs where the tendons attached to the bone that can get inflamed. So runner's knee is just a generic name, but it's usually a combination of overuse injuries that causes pain in the front of the knee. At least that's my experience of what quote unquote runner's knee is. But really, what is quadriceps tendonitis or tendinosis? What is patellar tendonitis or tendinosis? What is patellofemoral syndrome or chondromalacia of the patella? What is fat pad impingement or inflammation? What is bursitis, inflammation of a bursa? That's really the true. That's what we have to figure out. What is the exact area that's causing it? Because a runner's knee can be a million different things.
100% for sure. And that kind of brings us into the next question. You pretty much said it yourself. What is patellofemoral pain syndrome?
Yeah, it's just again a generic name, patellofemoral. Let's go through that first. So what is patellofemoral pain syndrome? The patella is the kneecap right here, and the femur is the thigh bone right here. So patellofemoral is between the patella, the kneecap, and the femur. And where that attaches, okay, where they, excuse me, articulate, especially when the knee bends. Look, when the knee's not bent, they're not really touching. But when the knee bends, there's a lot of pressure there. Okay, and if it's off center, there's going to be more pressure on one side of it than the other. And that's not totally uncommon, especially if you have muscle imbalances or anatomic alignment. Some people are more bony, bow-legged. Some people are more knock-kneed. There are some people have flat feet. All those things can cause excessive pressure in this front part of the knee. So anything that causes pain in the patellofemoral area, whether it's chondromalacia, softening of the cartilage, early arthritis, whether it is, I mean, the fat pad can get impinged. It can be quadriceps tendonitis and patellar tendonitis or tendinosis, wear and tear, but it's really more usually pain coming from kind of underneath the kneecap and in the actual kneecap area. There's a thing called a plica, which is a little band of tissue that can run between the kneecap and that fat pad in the front, and that can snap, crackle, pop, and give pain. So patellofemoral pain syndrome is just a generic name for pain that comes from the front part of the knee, especially where the kneecap, the patella attaches or articulates really with goes against, tracks against the femur, the thigh bone.
Makes sense. Makes sense. Yeah. Next, that what we have is, and you kind of talked about it in your last answer again. You're talking about the feet. So the question is, can knee pain be caused by the ankle or ankle, foot, and hip?
Yes, yes, and yes. Knee pain can be caused by the ankle. Knee pain can be caused by the foot. Knee pain can be caused by the hip. Let's go with foot and work our way up. So someone who has flat feet, they can get pain in the front of the knee because when you have flat feet, it makes your knees a little bit more what we call valgus, which is knock-kneed. And so what that does is it causes your kneecap to track more to the outer side and causes abnormal pressure under the kneecap. So just having flat feet can cause pain under the kneecap in that patellofemoral pain syndrome that you were talking about. So sometimes just getting an insert, an orthotic or an insert can change the alignment of that kneecap. And there's other things we can do too, which you guys work with, including strengthening muscles on the inner side of the knee versus the outer side to pull that kneecap over. Tons of different things we can do. But one piece of it is the feet. And so just as something as simple as putting an insert in medial arch support along the inner side of the foot can take the pressure off the kneecap. On the opposite way, if somebody is bow-legged and there's more pressure on the inner side, the medial side of the knee, if they're more bow-legged, sometimes we can put what we call a lateral heel wedge under the outer lateral, the outer part of the heel, and that will take the pressure off the inner side of the knee joint, and that can help people who have arthritis. So there absolutely are quote unquote simple things that can be done with the feet that can help the knee. Now, in some regards, sometimes taking the pressure off the inner side of the knee can put more pressure on the outer side of the knee. And now you can sometimes get some pain on the outer side of the knee. So you have to be aware that messing with the alignment can change the pressure on a different area and sometimes cause symptoms there. That's where you guys are the experts making sure that doesn't happen. Can an ankle cause pain in the knee? Absolutely. If you have a tight Achilles tendon, which is that big rope-like structure in the back of your calf, at the bottom of your calf that attaches to your heel bone, if that's tight, that is going to cause people to walk not correctly, and that can also cause pain inside the knee, including the front of the knee for that matter, even in the back of the knee sometimes, depending on what the exact problem is. So yes, the ankle can cause issues with the knee, and the same thing with the hip. If the hip is tight, that can cause issues with your quad muscles. I mean, because the quad muscles in the front of your thigh, they attach up above the hip joint and they attach below the knee joint. So they go across the hip and the knee. So not only can they affect the hip, but they can affect the knee. And I'm simplifying things here. You as a physical therapy assistant, certified strength and conditioning specialist, and certified VFit specialist, victory fitness specialist, can give more details on that. But the bottom line is, absolutely, the foot can cause pain in the knee, the ankle can cause pain in the knee, the hip can cause pain in the knee, and that's why when we do a CDE, a comprehensive diagnostic evaluation, which is what you were talking about in the beginning, that's why you guys are checking everything. You go to a standard physical therapist, the insurance is only going to pay for them to look at the knee and they don't have time to look at all those other areas. Good therapists will still do it, but they're handicapped and they only have 15 or 20 minutes of time to get all that done, whereas you guys have a full hour every single time you work with them.
Right, for sure. And that's with my experience, it's, looking at that flat feet, trying to correct that, whether it's with inserts, strengthening the posterior tibialis muscle, but also that Achilles, the tighter that is, the less dorsiflexion you're going to get. And that dorsiflexion is very important for like toeing off and things like that, which also brings the big toe, the hallux extension. That's also a big thing is having that mobility in both dorsiflexion and with the hallux, the big toe. So that's really three of the biggest things that we look at, but there's obviously more. Everyone's different. So looking, having that time to look at everything is
Oh,
important.
so you have seen, and I've seen you guys do this. Literally, you work on the tightness of their Achilles, maybe the tightness of their big toe, the tightness, and work on some strengthening exercises for the muscles around the ankle, and all of a sudden their knee pain's gone. Like, wow,
Oh yeah,
right? So we see that all the time.
for sure. And then just the last part of the question, how can hip problems affect knee pain?
Well, I am going to, so the bottom line is hip problems can cause pain in the knee, and I'm going to ask you some specifics on that, like you just did for the ankle and foot, which I thought was great. But here's some things that are interesting that people don't realize. You can have a problem in your hip, and it can refer pain into your knee. It's just the way we're wired, our nervous system's wired. Just like people who have a heart attack, the heart's on the left side, they might get pain in their shoulder or pain in their jaw or their neck, and that's the first sign of a heart attack. They're not getting pain in the heart. So you might not necessarily be having pain in your hip. And when we talk hip, the pain coming from the ball and socket joint is in the groin area. People always point to their butt and they say, I have hip pain. No, that's coming from your back, 90 whatever percent of the time. And then maybe a few percent of the time coming from your SI joint where your pelvis attaches to your lower spine, and then rarely coming from the actual hip joint itself. So if you have hip pain, it's usually ball and socket area. Well, what about the pain on the side of my hip? And they point to the side. That's usually bursitis or tendonitis or tendinosis, wear and tear of the tendons that attach to the side of your hip. So that's not coming from the ball and socket joint. So that's all stuff you have to understand. And tightness in some of those muscles can cause restrictions in the knee, which leads to knee pain. But just having arthritis in the hip can give knee pain, or just having a problem like an infection in the hip or a fracture in the hip can give pain in the knee. My father-in-law recently fell, broke his hip, and all he was complaining about was pain in his knee. But he didn't have any issues with his knee. He had a broken hip. So you can get referred pain from the hip into the knee. And so if someone is having knee pain, you always got to check the joint above the hip and the joint below, because we've seen people they've been told they need a knee replacement, and we get x-rays of their knee and there's no arthritis and they have full range of motion, great strength, really no tenderness of the knee. And we move their hip around, their hip doesn't even move. And so we get an x-ray of their hip and there's severe arthritis in their hip, and they probably need a hip replacement or they need regenerative treatments to the hip. And a lot of people don't want to get that hip replacement, but they sure as heck don't need a knee replacement. And so you really want to make sure you're always examining the joint above and below the one that the patient is complaining of. Now, I'm going to hand it over to you to give some specifics on things like maybe hip flexor tightness, meaning the muscles in the front or tendons in front of the hip, and how that can lead to knee pain and what you guys see, and then what you guys do to almost get immediate relief in knee pain sometimes just by working on mobilizing the hip.
Yeah, yeah. So really with that hip flexor, that's a very common tight muscle. A lot of the times all you have to do is load it. You would think tight muscles, you have to stretch, 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 stretch. But a lot of times it's really just loading it and getting it stronger. But, if that's limited, it's going to cause, imbalances in the pelvis. You could get a anterior pelvic tilt, and it's also going to reduce that stride length when you're stepping. You're not going to be able to get as much hip extension, and hip extension is very important, and it can help lead to weak glutes as well because that hip flexor is firing so much and it's so tight. So that is something that we definitely take a look at using Thomas tests, special tests in order to see the tightness and the integrity of the hip flexor. Another thing for the hips is definitely the strength of the hips, particularly the gluteus medius, which plays a role in the valgus knee positioning that is very prevalent in a lot of patients that we see. When that valgus is when that knee is, diving inwards towards the midline of your body. So, if you're able to strengthen up that hip and get that knee to align, track over your toes more, you should be able to see at least the big toe on the inside of your knee when when that knee is bending or you're going like into a squatting position. So ensuring, that the hip mechanics, are in line with the knee and in line with the ankle and foot is very important because then, every step that you're taking, you're just putting more pressure on, the ligaments on the inside and also putting more pressure on the lateral side, the compression. So big thing is really the mobility of that hip flexor, the strength of the gluteus medius. And we do notice a lot of times when we, get mobilization into the hip, whether it's an anterior glide, lateral glide, inferior glide, that loosens up the hip and lets them get more mobility. Then you got to strengthen in those ranges that you just gained, and then you'll notice that it's going to start sticking. And once that sticks, you're able to walk better. And once you're able to walk better, you're taking a lot of pressure off of that knee that you've been, d day through day, thousands of steps a day. It's going to add up and accumulate and lead to problems in the long term.
Think you touched on something that I want to expand on because you gave a lot of technical jargon there, which is good, but also kind of a cool thing. So a lot of people think, oh, I have a tight muscle or tight hip or tight this or tight that. I need to stretch it. And stretching can help some, right? But you made a really important point. It's not just stretching. As a matter of fact, stretching is not as important as actually strengthening. Or when you say loading, you're talking about strengthening, right? In the right way. So you guys load or you strengthen that joint or those muscles in a certain way. And we've seen that all the time. Like someone's range of motion isn't that great. And then you have them do certain strengthening exercises. And then you test their range of motion and it's so much better. And they haven't even stretched. So stretching can kind of help. It's not the most important thing. That I mean, I think it helps some people more than others, but there's also other mobilization techniques that you guys use to kind of glide a ball or a socket or a joint or a tendon or a muscle that will also help loosen things up. But the thing to make it stick is usually strengthening or loading it in the proper way, correct?
Correct, correct.
Yeah,
That's
it's
my
amazing.
biggest thing is, you're gaining ranges, but then you have to strengthen in those ranges to have them because if you're not gaining those, if you're not getting those ranges in the past, your muscle's not working in those ranges, so
It
they don't
never
know how to
has.
work
Yeah,
in those ranges anymore. So you have
exactly.
to reteach
Exactly.
it. We call it functional range conditioning, and uh,
Yes.
it pays off. It pays off.
Right. So you gain some range of motion. You haven't maybe gotten that range of motion in years. So now you got to strengthen the muscle in that range, in that certain range. And it's not easy to do, but that's why you guys are experts.
100%. Yeah. Next question we have is why does my knee hurt when going down the stairs?
Got a lot of anterior front knee pain questions today.
Yeah.
So when you go down the stairs, okay, look, this guy just tore his patellar tendon. He's going to need surgery. So when you go down the stairs, the knee is usually in a bit of a bent position, and that's putting a lot more pressure on the. And you can see the kneecap is when the knee's bent, that kneecap is more locked into this groove than when the knee is straight, right? So as you're going down the stairs, number one, you're usually more in a bent position, which puts more pressure on the front of your knee. Number two, you're using these quad muscles to walk down the stairs. And so it puts, if you already have some arthritis or you already have some imbalances or you already have some tendonitis, inflammation of a tendon, or tendinosis, degeneration of a tendon, or you have an inflamed plica or you have an arthritic joint, it's going to cause more pressure. And if you're not, if you have some stiffness in your knee, or you don't have the right muscle strength or imbalances, and have some imbalances, it's going to hurt. I guess that's the simple way of putting it. But usually, walking downstairs is going to put a lot more pressure on the front of the knee. Walking upstairs, it can put pressure on the front of the knee, but as you push up, it's going to put more pressure kind of on the back part of the knee. So going downstairs tends to give more issues in the front, but that's all stuff that can be worked on by strengthening that quad. All the stuff we just talked about, even from the hip all the way down to the feet, is going to help you get down the stairs. It's not just your quad, but your quad does help.
100%. 100%. That eccentric control of the quad, like I was saying, where the ankle, getting that dorsiflexion, letting that knee travel over the toe is huge. So, um, the next one we have is why does my knee hurt when I am sleeping?
Okay. Why does my knee hurt while I'm sleeping? I have no idea. Meaning, it could be a million different things. It can be a bazillion different things. So next time that person asks that question, tell them to be more specific. But it can hurt because let's just use arthritis for an example. So we see a lot of people who have arthritis in their knee, and arthritis is where the cartilage on the end of the bone wears down, kind of like the tread on a tire, and it gives them pain. So arthritis typically, when you wake up in the morning, you're a little stiff. I mean, we're all a little stiff anyway because our joints are made for moving, but when you have arthritis, even more stiff. But as the day goes on, you loosen up and you feel pretty good. Then as the day gets a little bit towards the end of the day, it starts to swell up, starts to ache and hurt more. Now you go to bed at night and you're not thinking about as many things. Like you have a lot of distractions during the day. You're like right now, if I was having knee pain, I'm talking to you, there's lights on, I'm looking at things, I'm distracted. My brain's distracted at night, the lights go out, you close your eyes, and that you're much more focused on the pain. So I think that's one reason. Um, it can be, and that can be whether it's from arthritis or tendonitis, inflammation of a tendon, or bursitis, inflammation of a bursa, or any of these things that cause pain in the knee. Usually, you're going to notice it more at night. Now, why do I have, like, let's say you don't have any pain and you go to bed at night and you get pain in your knee. Is that really coming from your knee? Could it be a position that your back is in? Could it be a position that your hip is in that's causing pain into your knee? Because if you don't normally have pain, and then when you get into bed and you're in that lying down position, and now you get pain in your knee, now I start worrying about, is it really the knee? Or could it be something else? Um, what else could cause? I mean, also people say knee, but sometimes it's like cramps in their calf. And so people get cramps when they're in bed at night. A lot of times that's because they're dehydrated. There's a whole bunch of other reasons for cramping. Another thing is, could it be a vascular problem? So some people sleep with their legs elevated because maybe they get swelling in their legs. Well, if you have a vascular problem and you're not getting good blood flow to your legs and your feet, you can have issues when you elevate your legs at night, and you can get pain in the leg slash knee area. And then some people who don't elevate their legs in bed get swelling. So swelling can give you pain too. So there's a lot of different reasons for pain. The most common reason for pain when you're in bed at night is that you don't think about it as much during the day, and then when you get in bed, you notice it more.
For sure. For sure. The next one we have is what's the difference between a strain and a sprain?
Great
There
question.
was a basketball injury recently, the Memphis Grizzlies, Ja Morant, and they said that he had a strained ankle joint. And I thought that was funny. But I just want you to describe the difference between a strain and a sprain.
Great question. So, a sprain is an injury to a ligament. A ligament connects a bone to a bone. So, if we have the knee here, this is the medial collateral ligament, the MCL, along the inner side of the knee. The ACL is deep inside the knee here, but let's just talk about the MCL. So, the MCL connects the thigh bone to the shin bone, the femur to the tibia on the inner side of the knee. So, a sprain is an injury to a ligament. So an injury to a ligament can be a little stretch. That's a grade one sprain. It can be a moderate stretch with some partial tearing, but not 100% torn. That's a grade two. Or it can be a grade three where this thing is completely torn, which actually I have a knee model right here, and this MCL is completely torn. That is a grade three sprain. A strain is an injury to a tendon or a muscle. So muscles contract and help our bodies move. But if you don't have tendons attached to the bone from the muscle, the joints aren't going to move. So you have a muscle, and then the muscle becomes a tendon, and the tendon attaches to the bone. So when the muscle contracts, the tendon gets pulled on and your joints move. So tendons connect muscles to bone. So they're the same thing. Muscle and tendon are the same unit, musculotendinous unit. So a strain with a T, tendon, T, strain has a T in it, tendon has a T in it. So a muscle or a tendon injury is a strain with a T. And so same grades. You can have a mild stretch, which would be grade one strain of a muscle or a tendon. Grade two is a moderate tear of a partial tear of a muscle or a tendon. And a grade three, it's completely torn in two. Now, if that basketball player truly had a strain of their ankle, that might be the Achilles tendon. That's a strain of the ankle. That might be the posterior tibial tendon or a tendon around the ankle. But more than likely, as you know, sprains are way more common around the ankle than strains are. So more than likely, it's a sprain of the lateral ligaments of the ankle. It can be any ligament of the ankle, but that's the most common sprain of the ankle. And the most common strain of the ankle is probably the Achilles tendon. So there you go.
Sure. And now, just kind of dovetailing off of that, how long can a muscle strain take to heal compared to a joint sprain?
Yeah, great question. In general, because you said muscle. So muscle is red for a reason. It has a really good blood supply, and the more blood supply you have, the quicker it's going to heal. So a muscle heals differently than a tendon, even though they're the same, even though you have a muscle strain and a tendon strain, you're absolutely right. A muscle strain is going to heal faster usually than a tendon strain because tendons don't have as good of a blood supply. Sprains also don't have as good a blood supply as muscles, maybe slightly better. Excuse me. Ligaments also don't have maybe as good a blood supply as a muscle as just like a tendon doesn't have as good a muscle a blood supply as a muscle. So sprains and strains tend to take a little bit longer to heal than a muscle, but it depends on the grade of the strain or sprain. So a grade one ankle sprain is probably going to heal faster than a grade three muscle strain. Okay, so in general, I would say muscles tend to heal faster than tendons or ligaments. But a grade one sprain or strain, doesn't matter whether it's a muscle, tendon, or ligament, it's going to heal faster than a grade two or three sprain or strain. Now, in general, a sprain or a strain is going to take 3 weeks to 3 months to heal. I'll just give you that range. That's in general. Sometimes it needs surgery. It might take a little longer. But in general, sprains and strains take about 3 weeks to 3 months to heal, depending on their grade and severity.
For sure. Now I'm going to relate this back to our programs that we offer. Now, is PRP or bone marrow suitable for muscle strains?
It's absolutely the PRP and bone marrow aspirate cells, which has stem cells and other cells that help the stem cells, we use all the time for muscle strains, for tendon strains, for ligament sprains, all the time. And it works amazing, um, especially if you can treat it early on. So when you injure a muscle, for instance, we see a hamstring strain. You know, hamstring strains are really hard to come back from, especially during if you're mid-season. So anything we can do to help that heal faster is better. So you know, if it's a younger person, 20s, maybe 30s and younger. PRP, platelet-rich plasma, where we take your blood, we spin it down, we get the platelets out. Platelets have growth factors, kind of like fertilizer. We concentrate those platelets, concentrate the growth factors, inject it into the injured area. That works really well, especially early on. And there's different types of PRP, getting a little technical here. There's leukocyte-rich, leukocyte-poor. Leukocyte-rich has a lot of white blood cells, so it causes inflammation and it helps restart the healing process. These are great cases where if it's an acute injury, it just happened, you don't want more white blood cells. Your body's already inflamed. You just want fertilizer. So we go leukocyte poor and we inject it into the area that's been injured, and it tends to basically add fuel to the healing fire or add fertilizer to help with the healing. And in our experience, I know there's not as much research and studies on this, but adding, PRP is like fertilizer. Bone marrow cells is kind of like seeds or grass seed. So you can add fertilizer to a lawn. It's going to take a little longer to kind of thicken up. But if you add fertilizer to just a patch of dirt, it's not going to really, the grass is going to take a lot longer to fill that area in. Whereas if you add grass seed, the grass is going to get thicker and grow in faster, right? So adding cells, bone marrow cells, which has stem cells and other cells that help the stem cells, we found that helps a muscle strain or a tendon strain or a ligament sprain heal even faster. That requires harvesting good stem cells from the pelvis, which is not that difficult to do, but it's a little bit more invasive than drawing blood from the arm, which is PRP. But the long answer or the short answer to that question is PRP and bone marrow aspirate cells are tremendous in our hands, and from what we've used for muscle strains, ligament sprains, and tendon strains.
For sure. Yes. And we actually have worked with a bunch of hamstring strains that we've used the PRP for, and it was with great results. So the next one that we have is, does sugar worsen arthritis?
Does sugar worsen arthritis? And I'll say yes. Now, why do I say yes? Because sugar, especially simple sugars, so let's just assume this person's talking about, because there's different type of sugars, right? Sugar is a carbohydrate. There's simple sugars, which are simple carbohydrates like sucrose and which is your table sugar, honey, fructose, which is in fruit. So simple sugars get into the bloodstream faster, cause a huge insulin response, and especially just like pure cane sugar, it's going to cause more inflammation. And inflammation causes heart disease, diabetes, cancer, but it also leads to swelling and inflammation in our joints and degeneration of our joints. If our joints are chronically inflamed, the surface of the joint is going to wear down faster. The tread's going to wear down faster. Plus, eating sugar, usually you gain weight. If you gain weight, you're going to put more force against, across your joints, and that's going to lead to more degeneration. Obesity has been found to increase the risk of arthritis, especially in knees. So sugar worsens arthritis. Yes, I will say that. It's not direct, it's indirect, but it does.
Next one we have is, does acupuncture help with arthritis?
Does acupuncture help with arthritis? Absolutely, acupuncture can help with the symptoms from arthritis. Seen it bunches and bunches of times. Acupuncture is not quite as common in the United States or in, Western medicine. It's more than it used to be. And I always say this, acupuncture wouldn't be around for thousands of years if it didn't work or have benefits. So I do believe, and I don't know as much about it as as I could, because we're not trained in Western medicine very much on acupuncture, but I know enough about it that it absolutely can help decrease inflammation. It can help decrease pain. There's no evidence that I know of, and I know there's some people who say this, but there's really no evidence that it grows back new cartilage. And if it does, it's very minimal. I'm not saying it can't decrease inflammation, which can slow the arthritic process down. It can absolutely decrease pain, swelling, increase blood flow. So there's lots of things that it can do. And so I have no problem when a patient says, "Hey, I want to go get acupuncture." Go ahead and try it. I've never seen anybody, I'm not going to say this can't happen, but I've never seen anybody be harmed from acupuncture if they're being treated for their knees. Now, not everybody gets relief, and most people get some relief, but it's not like earth-shattering. And not to say that there's not some people who do get earth-shattering relief, but my gut feeling is if it's severe arthritis and they get acupuncture, it can help with some of the symptoms, but it's not going to be earth-shattering. Whereas, let's say they were having pain from their back or a nerve problem or some non-knee problem, but it was giving them referred pain to their knee. I've seen some miraculous results and their pain goes away completely. So, acupuncture can help the symptoms from arthritis and a lot of the secondary things that we see, like swelling, inflammation, pain, stiffness, loss of range of motion, things like that.
The next one that we have is, How does heat affect arthritis?
How does heat affect arthritis? I don't think heat affects arthritis directly, meaning, and by the way, well, I don't think let me just start that over again. I don't think heat affects arthritis directly unless it's like you're in a fire or you get a severe burn and that causes direct damage to the cartilage. Absolutely. That type of thing can, even in the operating room, we use electric cautery wands. If someone's not careful and they touch that electric cautery wand to the cartilage, it will damage the cartilage and that will lead to arthritis. So it depends on what type of heat we're talking about. I'm sure the person who asked this question is talking about a heating pad or something like that. So let's just use that for purposes. Um, Putting a heating pad onto an arthritic knee because it's sore or swollen can help the symptoms. The warmth increases blood flow, and sometimes that can help swelling go away if it's not acute swelling, if it's chronic swelling. If it's a new injury, you don't want to put heat on it because you don't want more blood flow and more swelling. You want to put ice on it to decrease the swelling. And even that could be slightly controversial too, believe it or not, because swelling in the beginning is part of the healing process. But as far as like a chronic condition, meaning it's been there for months or years, like arthritis that takes a long time to develop, heat will increase blood flow, make the tissues more pliable, loosen up. And so it helps with the symptoms from pain. It feels better and it can help with range of motion. It does nothing to grow back new cartilage or cure the arthritis. So there's my answer to that question.
For sure. And we utilize heat here, usually not with a heating pad though. We like to generate our own heat, getting the muscles working, getting, the blood flow to the area. So we try and generate our own heat to the muscle naturally just by, moving and getting those muscles activated. Does help to,
Which is always the best, which is always the best and always works better because you get the entire deep, superficial, everything gets warmed up because all your blood vessels, everything's moving. So
exactly,
absolutely.
for sure. Next one, which is kind of similar in a way. I believe it's, in a way doing the same thing, just in a different mechanism of, doing it. Does massage help with arthritis?
So does massage help with arthritis? Massage does not grow back new cartilage. Arthritis is where the cartilage on the end of the bone wears down, like the tread on a tire, as we've talked about. But massage absolutely can help get swelling out of the knee, can get swelling out of the lymphatics. That's how your swelling gets out of things, out of our using our lymphatics. Any fluid that leaks out of our blood vessels, our capillaries, which are our smallest blood vessels, goes into our lymphatic system, and then there's lymphatic vessels that go back to the heart eventually, and then that fluid circulates back in your blood. So absolutely massage, certain types of massage can get swelling out, can get range of motion back, can heat tissues up, um, can help with pain and symptoms. It feels good, so their massage can help a lot with symptoms, but it won't grow new cartilage back or cure arthritis. But massage is great if people are doing it correctly, nothing wrong with it at all.
For sure. Next one we have, and this one's actually about the ankle. Um, the question is that we received is walking good for ankle arthritis?
Okay, so is walking good for ankle arthritis or frankly knee arthritis or hip arthritis? Anything where you're walking, you're putting more load or weight through your lower extremities, including your feet. So arthritis is where the cartilage wears down. And when the cartilage wears down, more and more force gets transmitted to the bone underneath. And sometimes the bone can start to break down faster than the body can heal itself. And you get these soft spots, these stress or microfractures in the bone. It can be in the feet, it can be in the ankles, it can be in the knee most commonly, it can be in the hip, it can be in any of the bones. And so that is usually what causes pain because bone has millions of pressure sensitive nerve fibers, and the pain from arthritis usually comes from the bone, not always. But if someone has advanced arthritis, then walking or impact loading exercises isn't necessarily the best exercise. Riding a bike, or non-impact loading exercise like an elliptical or water running or water walking are better. Now that's especially initially. That doesn't mean that people who have knee arthritis or ankle arthritis or foot arthritis or hip arthritis can't walk and that we can't get them back to walking on a nice walking program. But they need a full evaluation first, right? I can't answer that question without really knowing what that person do they really number one, do they really have arthritis, right? Number two, how bad is the arthritis? Number three, are there other factors involved? Number four, what did you guys say about their ankle mobility, their hip mobility, that the whole body working, the upper body can affect the lower body, the core, all those things. And do they have flat feet? Do they not have flat feet? So that's why answering questions like this is very difficult over a medium like this. But answering questions like this is simple if we do a full comprehensive diagnostic evaluation, getting full circle back to what the beginning of this was talking about. If I know, their whole history, if I examine them, if I have x-rays, ultrasound, MRI, you guys have evaluated them, we all get together and we talk, I can answer that question with probably 98 to 99% accuracy. So point is, these are great and these questions are all great, but really, if you want the best answers, you can't shortchange yourself and just ask simple questions. You really need to get in and be fully evaluated by experts who do this stuff every day. And that's what we do. That's like, I have a rattle in my car. Is it good to drive over bumpy ground? Well, what's the rattle coming from? And is the bumpy ground going to make it worse? And is there some bigger issue? Like, you can't answer that question. You would never ask your mechanic that. Or if you did, they would tell you the same thing. You got to get in and come in for a full evaluation. We got to figure this out. And sometimes it's simple. Sometimes it's very complicated. Maybe your strut was going to go and break. And maybe, you getting in saves you a bigger problem, right? So these are great. But really, if people want to know full answers to their questions and the best answers, then they really need to get into experts who know what they're talking about and spend time with them. I'm going to pull a plug for ourselves because we do that. That's why we got out of traditional healthcare. You can't do this stuff in 7 minutes or 15 minutes or 20 minutes. And so people want answers to those questions. I could answer it depends on every single one of the questions that you just asked me because it does depend. And I'm giving general answers. And if people want specific answers, they need to come in because every person's different, every person's situation is different.
100%. Last question we got. So you were talking about, people coming in and really seeing what's going on. So say somebody came in for their CDE, and committed to one of our programs. Um, what should be their expectations in the first 24 hours after getting a PRP and bone marrow injection? And let's say that it's, your classic, bone on bone arthritis. I wouldn't say there's any like meniscus involvement. Just, for arthritis.
From 24 to 48 hours, you said?
Yes, just the first 24 hours. Yep.
Okay, well, we are basically trying to get that joint to heal and remodel. And so we're stimulating, it's stopped healing, it's breaking down. We want to stop it from breaking down at the least, because some people are too far gone and so, you can't make an 81-year-old knee look like an 18-year-old knee. But if we catch it early enough, sometimes we can prevent the arthritis in the first place. And we've done that. We've seen cases of that. But if someone has a lot of arthritis in their knee, we're trying to at least stop the degeneration and we're trying to stimulate a healing response to help heal the inside of the joint, areas that need healing, and remodel the inside of the joint to make it better, kind of like that show Fixer Upper. So we do want a healing response to start. So point being, when we do a procedure and we inject PRP, platelet-rich plasma, or bone marrow aspect cells, which has stem cells and other cells that help the stem cells into a knee or into the bone where the soft spots are, there is going to be some pain and discomfort, not as much as a knee replacement or a big surgery, and there is going to be a healing response. So um, I had a relative who just went through this. I can't say, I'm trying to be HIPAA compliant here, but one of my family members literally just had this done Monday and they had it done on their knee. And so the first night it was pretty sore. And yesterday it was pretty sore. And it was done Monday. Today's a Wednesday. So I'm interested to see how this person is doing when they come in for their first VFit appointment today, which will be very shortly. But the point was, they said, "Oh, it's pretty sore. It got really sore overnight, and it was sore during the day. Yesterday, took some Tylenol, it felt better." And I said, "That's a good thing. That means your body is reacting. We want that. So we want to restart the healing process." Which does lead to some inflammation, some swelling, which is all part of the normal early healing process. Chronic inflammation, chronic swelling, no, but early on, that is normal. So the first 24 hours, they are going to expect, and we hope that they're going to get a healing response, which means there is going to be some swelling, some inflammation, some pain, some discomfort, but nowhere near, not even close to like a huge incision for a knee replacement and, putting, metal, plastic, and cement into somebody, that is going to cause a lot more pain in the first 24 hours. I didn't have that procedure done on my knee, but I had it done on my elbow. And that first night in bed, it was pretty sore and swollen. And I said to myself, if this stays like this forever, I would hate this. But I didn't say that because I knew, and we tell patients this as well, you are going to feel that. That's normal. That's a good thing. That's your body reacting and your body starting to heal itself again. And I knew that first night I could barely move it. By the second day, I could move it more. By the third day, I could get it all the way straight. By 2 weeks, I was overdoing it, which we see that sometimes too. But 2 weeks after a knee replacement, it's hard to overdo it. So you're going to initially have probably the first 3 days, it's going to be pretty sore. And then it starts to get better. First 2 weeks, maybe the, quote, roughest, which aren't certainly not severe. And then after that, sometimes we got to hold people back, as you know.
For sure. For sure. And should they expect to, have a huge bandage wrapped around their knee? Are there going to be staples in their knee? And
Great
are
question.
they usually are they able to walk out of the office after the injections? Like
So
how does that work?
yeah, great question. So we have never had a person, we've been, doing these knee repair, not knee replacement programs for years, but really the last, I'd say since COVID, especially, and people walk in and walk out. I haven't seen a single person not be able to walk in and walk. They might limp in, and some people limp in and they walk out better, actually. Some people limp in and limp out, but they can walk in and walk out. And you can't do that with a knee replacement, obviously. We are not doing incisions, we're just doing little poke holes. So think of it as needles, so I'm not going to say it's not non-invasive. There are needles, but a lot of people out there have already had shots, know what needles feel like. We numb the skin up. We try to make it as pain-free as possible. We do have a very light sedative if people want to. It goes under the tongue, it absorbs, and it makes people feel relaxed. I think that's the most common thing that it does. Not everybody wants or needs that, but we found these things called MKO melts are very nice for getting people relaxed. And who wouldn't be anxious about going into any procedure? I was anxious, even though I knew Jordan. I trained him well, and he was going to do my procedure. Of course, it's normal to be nervous, and those MKO melts help a lot. But they should expect just some poke holes, walk in and walk out. Dressing. It depends if we're injecting into the bone or not. If we're injecting into the bone, there might be a little bit more oozing or bruising, so we'll put a little bit more of a dressing on. But usually it's just some gauze pads, some ABDs, which are a little thicker, and an ACE wrap.
Not bad. Not bad at all. Um,
No, no staples, no sutures, stitches, none of that stuff.
yeah, that's awesome. That's awesome because those can be irritating at times too, especially the staples trying to get over pant legs and things like that. So,
For sure.
no, that's important. Well, Doc, thank you so much for answering these questions today, and thank you to all of our fans out there on social media for submitting them. If you have a question you would like Dr. P to answer, be sure to join our Skool group linked in the description below and try to be as specific as possible, but understand that we cannot diagnose your situation. We could just give general information. Um, as the date of this recording, it is free to join that Skool Games group. Be sure to follow us on social media at Victory in Motion 1, and be sure to follow Dr. P on social media as well, Dr. Marc Pietropaoli, and that's Mark with a C. We will see you on Ask Dr. P next Wednesday at 9 p.m. Hope to see you there. Thank
9
you,
a.m.
Doc.
too. Either way, 9 a.m. Right,
All
Lucci.
right.
Thanks, everybody. Appreciate it. Have a great week.
Thank you.